All right, let's get started. Good morning, everyone. It's my pleasure to welcome you today to today's Region 4 Project Echo session from the Emory University School of Medicine's Serious Communicable Diseases Unit, which is run in conjunction with the Southern Regional Disaster Response System and the National Emerging Special Pathogens Emerging Special Pathogens Training and Education Center, or NETEC. So we are very happy to have you here today. My name is Jill Morgan. I am an ED and critical care nurse by background, but now I'm the site manager for our biocontainment unit here at Emory, and I am standing in for Dr. Gavin Harris today. So I will be your host, and I'm happy to be here with y'all. I'll learn more about measles and what we can do to better prepare our healthcare systems. All right, so as always, we will start just with a little bit of background about the Echo sessions. We will be recording this session, and when you registered, we did collect some of your data, which will be used for information purposes only, and we will be kept confidential. The ECHO program itself, if you're not familiar, is actually an acronym for Extension for Community Healthcare Outcomes that was originally founded by the University of New Mexico and has been used during the COVID pandemic and now beyond to really disseminate good information and amplify best practices in a collaborative environment. So we are really grateful for this platform and also for your participation. So we're looking forward to a robust session today. And if you have other questions or suggestions, then please reach out to us. We'll have all the contact details at the end of today along, and they're also on our website. So we're happy to have you and to have your feedback. I think everybody by now probably can do Zoom in their sleep, but just please remember that if you're having any IT issues, you can send a message to the IT Echo in the Zoom's chat. And if you have a question, though, please put it in QA and not in chat, just so that we can kind of scan and make sure we're getting the right information. And we will be trying to fit in a Q&A session at the end, and we really appreciate some of you sent in questions when you registered. So we are grateful for all of that. All right, so our disclosures, none of our presenters today have any financial or conflict of interest to report. And our agenda for today. So we're going to do or have a SITREP report or a situation report. We'll be doing some poll questions and then doing a case presentation and some didactic conversation, really with two great experts in this field, and then some Q&A. So yeah, I'm looking forward to getting this started. All right, so happy to introduce our two speakers for today. So we have Dr. David Greenky. He is an assistant professor at Emory University School of Medicine and pediatric emergency medicine physician at Children's Healthcare of Atlanta, or CHOA. He's also the lead for their biocontainment unit, or what they call their special pathogen or special care unit. And that just happens to be the largest pediatric biocontainment unit in the country. So we are grateful to have him. He is also the principal investigator for the Gulf 7 Pediatric Disaster Network here in the Southeast. He sits on the executive committee of the American Academy of Pediatrics Council on Children. So very happy to have Dr. David Greenky here. We're also joined today by Vanessa Aden. She's a vaccine preventable disease epidemiologist, the team lead and subject matter expert for the Georgia Department of Public Health's acute disease section in vaccine preventable illnesses, and she is responsible for developing the guidance and the education for the diagnosis and the investigation and treatment and control, really, of these vaccine preventable illnesses. So we are thrilled to have both these folks here. Vanessa's section really is charged with providing support to formal programs and to look at the evaluation of projects related to the burden of vaccine preventable diseases, which sounds like a big job. So we are excited to have these people here with us today and to hear more about measles and how we can better prepare our healthcare systems. And now we'll go on to our SITREP.
Hi, I'm Gavin Harris with the Region 4 SITREP. To Africa first, Nigeria. Lassa fever, as of the most recent available report 2 weeks ago, has claimed 176 people. This year, the country has confirmed 955 infections among 8,367 suspect cases, with an increased case fatality rate of 18.4% compared to 16.6% in 2024. It's believed that poor sanitation and late presentation of cases has contributed to this. We are currently entering the peak dry season in the country, and case counts are expected to rise. Global risk of spread is currently moderate. Next, to the Democratic Republic of Congo, DRC, which declared an outbreak of Ebola virus disease on the 4th of September. On the 19th of October, the last Ebola patient receiving inpatient care was discharged, marking the beginning of a 42-day countdown. There are currently 10 days left. In sum, 64 cases have been reported, 53 confirmed, and 43 fatalities. Global risk of spread is currently low. And lastly, to Ethiopia, which on Friday, the 14th of November, declared the country's first outbreak of Marburg virus disease in the South Omo zone of the southern regional state. This is a zone bordered to the south by Kenya and Lake Turkana and to the west by South Sudan. In Jinkatown, 17 suspect cases have been reported with 9 confirmed, several among healthcare workers, and 3 deaths. International teams, including those from the WHO, Africa CDC, and US CDC, are deploying to assist, and we do expect case counts to increase given the porous borders in the region. Global risk of spread is currently low. Next, in Southeast Asia, Cambodia confirmed the death of a 22-year-old man from H5N1. This is the 18th case in the country this year and one without a clear source of exposure. And like the most recent cases of the virus in the country, this has also been determined to be a reassortment virus between the older H5N1 clade and the newer one that is circulating globally. Global risk of spread is currently low. And in the U.S., the Washington State Department of Health has confirmed the first ever human case of H5N5, a highly pathogenic influenza strain subtype in a Grays Harbor County resident. The current patient, with underlying health conditions, is reported to be hospitalized and in serious condition with fever, confusion, and difficulty breathing. The source of the exposure is believed to be a mixed backyard poultry flock with exposure to wild birds, yet investigation is ongoing. No additional cases have yet been detected, and the domestic risk of spread is currently low. Finally, there have been no reports of suspect or confirmed patients with special pathogens of concern in Region 4 at this time. For more resources, visit us on the web at scdp.emory.edu.
And as usual, we will get that SITREP posted so that if you want to refer back to it, you can go to our website to get that. All right. As usual, we're going to start with a poll question. Today's first question is, how knowledgeable do you feel about the current epidemiological state of measles in the U.S.? So I know that some of us have our noses just into our own worlds right now, but really thinking about across the United States, how are you feeling about that? So your choices are not at all knowledgeable, slightly knowledgeable, somewhat knowledgeable, very knowledgeable, or extremely knowledgeable. And our second question, how confident do you feel about the appropriate clinical management of a patient with measles? And again, same sort of Likert scale from not at all confident all the way up to completely confident. All right, answers are still coming in, but it looks like a pretty good bell curve here, but almost nobody at the extremely knowledgeable edge of their understanding of the current epidemiological state. So we've definitely got some work to do here, and that's good because we have the right people here to do it. And for our confidence level in clinical management, I'm happy to say it's sort of a pretty good mix between slightly, somewhat, and fairly confident. So a few more people are completely confident, and that's also good for those folks who are manning our front line. So we're grateful to y'all for answering that question. I think that we'll definitely be able to fill in some of those gaps today. All right. We are going to get started with Dr. Greenky. So David, I'm turning it over to you.
Perfect. Okay, let me Share my screen here. All right. Is that good? People see my screen?
Yes, thank you.
Perfect. Okay. Well, I have good news in terms of the clinical management of measles. It's not very complicated, and we'll talk more about that. Um, so I'm David. I'm a pediatric emergency medicine physician at Children's Healthcare of Atlanta and Emory, working mostly at Arthur Blank Hospital and then also at Hughes Spalding, which is kind of one of our smaller sites next to Grady. And thank you for having me here and looking forward to discussion. So we're briefly going to go over just a very simple case presentation, and then we're going to review, identify, isolate, and inform with a focus on measles. And identify, isolate, and inform was taught to me by Andy Shane, but it's a well-known structure to think about infectious disease, and it's something that Dr. Shane emphasizes. And it's a really nice, simple way to break things down. And if you follow this, you will not make a mistake. So here is an example of a case. We have an 11-month unvaccinated child who's had cough and fevers and red eyes for a few days, and then recently developed a rash, maculopapular rash, has not been drinking well, has voided twice in the past 24 hours. Just so you know, for us, we usually say 3 to 4 urinations in a 24-hour period means we're getting enough. So this child has not gotten quite enough to drink. And this child has, making it easy for you, this child has a recent family travel to New York. And already we know that the child has a sick contact there that was diagnosed with measles. On exam, child is ill appearing but non-toxic appearing. Awake, has an occasional cough. You notice some of these small bluish white spots on the inner mucosa of the cheeks called Koplik spots, and you can see an example of that in the picture below. You notice that there is some conjunctivitis and some congestion, and patient is a little bit tachycardic. Abdomen is soft, non-tender, not distended. Cap refill is a little bit delayed, and the child is a bit fussy and otherwise has an appropriate neurological examination for age. So let's talk a little bit about measles. Um, so infection, so first, the first symptoms you're going to see and the most common symptoms you're going to see are very similar to other viral illness symptoms in children. So you're going to see cold-like symptoms, cough, congestion. You might see some viral conjunctivitis. The trifecta that we always talk about is cough, coryza, and conjunctivitis. The three C's. The coryza is a fancy name for congestion. And so those present within 7 to 14 days of exposure. And then after those start to present about 2 or 3 days later, you might see some of those spots in the mouth that we just talked about, the Koplik spots. And then 3 to 5 days after the cold symptoms appear, you often see a rash that starts usually on the head and works its way down. And then some children, that's all you see. You see just this viral contagion illness. And then, of course, there are complications that can occur for measles, which is, why we care about measles as opposed to other illnesses. Encephalitis, you can get ear infections, diarrhea, you can get measles pneumonia, and in severe cases, you can even develop blindness. And you can also develop into, it's not here, but you can develop into respiratory failure. And then there is something called subacute sclerosing panencephalitis, which is really something that comes much, much later, 7 to 10 years later after infection. And so measles is a pretty virulent disease. 20 to 40% of kids with measles under 5 require hospitalization for some reason. Often it's simply dehydration, might also be respiratory support, or it could be resulting from encephalitis. And uh, about 1 in 1,000 develop acute encephalitis, which is really dangerous. I'm going to pause for 1 second. My dog is going to go out, and if she doesn't, we will have an exposure problem here. I'll be right back. Go back, go outside.
I
Right.
think many of us can sympathize
I'm,
with
yep.
that dog need.
Yes, I know her habits very well. And then 1 out of 3 children will 1 out of 3 out of every 1,000 children who become infected will die, and that's either from respiratory or neurologic complications. So this is a really a virulent disease, and that's why we care about it so much. Just for your information, it is generally considered contagious 4 days before and 4 days after the rash appears. So, like I mentioned before, the care is really supportive. For the respiratory symptoms, you're going to have supportive care. You're going to be doing the things that you would be doing for any child with a viral respiratory illness who has escalation needs. So that would be oxygen, escalation of oxygen, some BiPAP, and then in the worst case scenario, intubation. Sometimes you give adjunct steroids. Antibiotics will not help with measles pneumonia. However, I will tell you that if a child is sick enough to be in the ICU with pneumonia, they will likely also be on antibiotics. Diarrhea and dehydration is treated with oral and intravenous fluids. Encephalitis, steroids, we might try IVIG or other things. Um, and then there are the longer term complications. We're not going to talk much about that today, but there are things to do for longer term complications of the encephalitis and the subacute sclerosing panencephalitis. So again, you're going to see high fevers. You're going to see this viral stigmata of cough, congestion, conjunctivitis. The child will just appear miserable or puny, we like to say. We in pediatrics don't like to use the word toxic unless we really mean it. So we use other words that portray similar things. You'll see the Koplik spot sometimes, the maculopapular rash about 14 days after exposure, head classically spreading from the head to the trunk. And here's just some examples of those things below. Now, and Jill, how am I doing on time? I just want to make sure how much time do I have left?
You are doing fine. You've still got several minutes left.
Great. I mentioned the treatment of measles is pretty straightforward. It's very similar to what we do for complications related to any viral illness. The key difference and where we can make a difference in measles, in my view, is the identification and isolation. So the early identification of potential patients, and then the proper isolation and then contact tracing of those patients. And that's really the important part and where we need to pay attention. And that's something that we could work on in all of our emergency departments across the country. And that starts with the triage screening process. I don't know how many sites that are joining us today are using Epic. Epic has an updated universal symptom screen and travel screen. This has been really helpful in helping us to identify and prioritize different patients based on risk level. Epic does this automatically for us, so I'm just going to briefly show you that, and then we'll talk about, of course, what you should be thinking about. So this is just screenshots of our triage screen at CHOA. So if you have been in contact with somebody who has been sick with something like measles, or first sick in general, and later on you'll see measles, that is very important to know. Our Epic will automatically actually take your symptoms and then your travel exposure and give you alerts based on your possible risk. So here's just some of the things we're asking about. Have you specifically had measles exposures? Are you immunized to these things? Do you have any recent travel history, which is important both for measles, as we know these outbreaks are geographically based, and certainly for the other special pathogens we're thinking about around the country and around the world, like Gavin had alluded to, we do have a number of active outbreaks around the world. The Epic travel screen automatically it is updated on at minimum a monthly basis, and it will alert us to potentially patients with risk. So, risk factors, certainly somebody who is unvaccinated, major risk factor. We know this vaccine works incredibly well. We want a 95% national vaccination rate to reach herd immunity. We are not there, and we are falling, and that is why we're seeing more cases. Exposure, so certainly the exposure history that we talked about, travel to a hot spot, medical conditions. So immunocompromised patients may not develop that typical rash. So it's, you always have to be a little bit more careful with patients with known history, complicated medical history. If we are concerned for a patient with measles, or a PUI, a patient under investigation, we need to undergo isolation for those patients. And at our system, we have very clear isolation guidelines. I would encourage you all to go check in your systems what the isolation guidelines are, if I would assume they exist, how to access them, and if how well they're being implemented. And because that is very important. So for measles, we have airborne isolation. So airborne is putting a patient into a negative pressure room if one is available, and then using an N95 mask. Okay, and that's just what that says. Now, I will note that if the patient is spewing fluids like diarrhea, then they should, in addition, be on contact precautions. If they're not, then if they just have the regular URI and the regular rash, then airborne precautions are sufficient for measles. On the patient and the family, you want to mask them. If you cannot put a mask on the patient, maybe they're too young to tolerate a mask, a loosely fitting sheet could be helpful. Ideally, they're in a negative pressure room or a airborne infection isolation room, which is the same thing, just different name. If that's not available, then placing them in a single room. If we are concerned about a PUI, healthcare workers who are measles immune preferably should be providing care. And just a reminder that the person is infectious about 4 days before and 4 days after the rash. So that is isolation, and next is inform. Hopefully, your local system has a process in place as to how to deal with these patients, but so you would immediately, obviously, notify the clinical leaders in the emergency department, and then discuss with your infectious disease experts infection prevention for your system, and then, of course, contacting the Georgia Department of Health or whatever Department of Health, whatever state you are in. And then we're almost finished here. I just wanted to give a little bit more information. So there was a recent research letter in JAMA that unfortunately showed us what we already knew, which is that vaccinations against measles and immunization rates are falling. This looked at 2,066 counties around the country. 78% of these counties reported a fall in vaccination rates. Currently, we're at 91%. That's down from almost 94%. And again, 95% is where we want to be for herd immunity. Here's just a graphical representation of that. You can see in 2019, there was a spike in cases, and there was a little bit of a lag of vaccination rate prior to that. And so you will see the dip in vaccination rate, and then a lag, and then a spike in cases. Then we're looking into the COVID years, which is an epidemiological sort of outcast, I would say. Why didn't we get a lot of measles cases, even though the big drop? Well, I think that had something to do with our behavioral changes during COVID, and also I think COVID just messed with how viruses were being transmitted around the country and around the world. But now you can see in 2025, we are seeing a massive spike, and that's been with quite an impressive drop in vaccination rates. So unfortunately, um, uh, this is probably not going to end soon. I just asked Dr. Shane for the most latest update. So about 1,700 cases in the U.S. In this current outbreak. Canada has recently lost its measles elimination status. There's currently a large outbreak in Utah and Arizona, and this is a border area and a highly unimmunized area. And then there's a resolving outbreak in South Carolina. And this is our last slide, I believe. So, you know, identify, isolate, and then inform. Fever, cough, and travel or exposure is really the things we should be thinking about. You need to mask yourselves and the patients and then isolate them. Um, and that's it. I wanted to thank Dr. Shane for her wisdom and helping me with some of the content on this presentation.
Thanks, David. That was great. And of course, Andy Shane has been a friend of this organization's for a long time and just is such a great wealth of knowledge. All right, well, we're going to transition sort of to the public health side of this and welcome Vanessa Aiden. So, Vanessa, come on down.
Thank you. Let me share. Oh, wait. It's asking me to, it's saying someone else is sharing. I think.
I got you. Hold on.
Okay. All right. Let me try again. Okay. Let me know if you can see my slides.
We can. Thank you.
Perfect. Well, thank you. And I think it's still morning, so good morning. So measles cases are rising, and travel-related exposures mean it could arrive at your facility at any time. Imagine a patient walks in with a high fever and a rash. Could your team respond quickly? So today I want to cover how to recognize, isolate, and protect both patients and staff. But I want to start by reviewing why measles remains a serious public health concern. So as of November 13th, there have been 1,723 confirmed measles cases nationwide. Most cases are in children and adolescents who are unvaccinated or who have an unknown vaccination status. This highlights how measles exploits immunity gaps. So there have been 3 measles-related deaths this year, 1 adult and 2 children, all unvaccinated. This slide highlights U.S. measles activity as of November 12th. So we've already had 45 outbreaks this year, and this is compared to 16 last year. About 87% of cases are a part of outbreaks, showing that measles spreads in clusters where immunity is low. So this really underscores why quick identification and response in healthcare settings is so important. This slide shows measles trends in Georgia from 2010 to 2025. So cases are usually low because of high population immunity, but recent spikes follow national trends, and this is mainly due to travel-related introductions and, of course, under-vaccinated pockets. But recognizing these patterns help us anticipate risk, respond quickly, and keep vaccination efforts strong. So I want to spend some time here and say that, when measles is suspected, every facility needs to do 3 things: identify, isolate, and inform. You want to identify the patient quickly, considering symptoms and recent travel. You want to isolate immediately to prevent the spread. And you want to inform infection control and public health for guidance on testing, contact tracing, and precautions. So clinical staff should recognize measles early: fever, cough, runny nose, red eyes, and a rash, especially in unvaccinated patients or those with recent travel or exposure. Collect travel history for 21 days, ask about exposures, and document symptom onset. Thorough history taking allows early isolation and notification. So as soon as measles is suspected, mask the patient immediately. Place them in a private room or ideally a negative pressure. Only essential staff should enter, all using proper respiratory protection, even if they're presumptively immune. You also want to know your facility's air handling systems. The goal here is rapid, safe isolation to prevent transmission. Have a clear plan for transferring suspect patients for testing or evaluations. Transfer patients efficiently to minimize exposure, and you want to isolate for 4 days after rash onset. For immunocompromised patients, they require precautions for the entire illness. Don't allow visitors. Controlled movement and limiting contact prevents facility spread. So when we talk about shared airspace, we mean any space that shares a common air handling system where air can move between rooms without filtration. So factors like ventilation, airflow patterns, and humidity affect how easily measles can spread. So to identify these shared airspaces, you want to consult with people that are familiar with the building's air system. So these are your HVAC engineers, your facility engineers, or your maintenance staff. And their input helps pinpoint connected rooms, which is key here for infection prevention. So air exchanges per hour, or ACH, tells us how often the air in a room is replaced each hour. So the higher the ACH, the faster the airborne contaminants like viruses are removed. So for example, 6 ACH takes about 46 minutes to remove 99% of contaminants, while 12 ACH only takes 23 minutes. So knowing this information helps estimate how long a room might stay infectious. You, of course, always want to consult with your HVAC experts, especially when you're using these numbers for infection control planning. So if you suspect measles, contact state public health if you're in the state of Georgia immediately. If it's during business hours, you want to call 404-657-2588. And if it's after hours or weekend, you want to call 1-866-PUB-HEALTH. You want to ask for a medical epidemiologist, and you want to provide travel, symptoms, and exposures to guide timely infection control. So to determine who's considered exposed, you want to focus on both timing and location of contact with the case. So anyone who shared airspace 30 minutes before that patient arrived through 2 hours after appropriate isolation is potentially exposed. So contacts include anyone who shared airspace with the case while they were infectious, and this is regardless of direct contact. Identifying all exposed individuals ensures proper monitoring and timely intervention to prevent further spread. So presumptive immunity means we assume someone is immune without lab proof. So for example, people with 2 MMR doses, a prior measles infection, or they were born before 1957. So knowing who's immune quickly helps protect others, and it prevents the virus from spreading. In the state of Georgia, presumptive immunity is assumed if someone has documented vaccination, lab evidence of immunity, or they were born before 1957. But in high-risk occupations or settings, we apply an even more stringent criteria to ensure protection. And when it comes to healthcare personnel, they are at higher risk for exposure and can spread infections to vulnerable patients. So they're considered presumptively immune if they have 2 MMR doses, a prior infection, or lab evidence of immunity, or they were born before 1957. So quickly verifying immunity helps ensure susceptible staff are able to get post-exposure vaccination or prophylaxis while also reducing outbreak risk and protecting everyone. So once exposed individuals are identified, the first step is to create a complete list of everyone who may have been exposed. The next thing you want to do is flag their medical records so other healthcare providers are aware of their exposure status. Any healthcare personnel who aren't presumptively immune or who develop measles-like symptoms should be excluded from patient care or high-risk areas until they are cleared. Following these steps helps prevent further transmission, and it also ensures post-exposure interventions such as vaccination or monitoring. So this Venn diagram shows the recommended key strategies hospitals should implement to prevent and contain measles. Hospitals should use three layers: administrative, which is screening, isolation, and staff training; environmental, which is the use of negative pressure rooms, ventilation, and cleaning; and personal protection, the use of N95, hand hygiene, and visitor limits. Overlapping measures like vaccination and isolation strengthen the containment, and all of these three layers are needed for an effective defense. So, planning is everything. Really, it's our first line of defense. Start by making sure you have an isolation room ready, a negative pressure room if possible, or at the very least, a private room with a door. Know who might have been exposed: patients, visitors, staff, and make sure your healthcare personnel have evidence of immunity. For frontline staff, this is your reception, security, and housekeeping. They also need to be able to recognize measles symptoms. And simple steps like putting up signs at entrances, especially after travel, can make a big difference. And planning doesn't stop at your own facility. You want to also coordinate with other healthcare systems and providers and keep regular communication with key clinical partners. You want to keep public health contact info handy for quick guidance on testing or next steps. And don't forget Georgia's Health Alert Network, or HAN. Sign up and check it regularly for real-time alerts and guidance. The point here is being proactive, staying alert, and working together keeps everyone safer, and it makes managing a potential case much smoother. And just to highlight a key resource, the health alerts sent out by Georgia DPH. These provide timely updates, guidance, and recommendations for outbreaks. This is including measles. And staying connected to these alerts helps your facility respond quickly and appropriately. And one more resource to keep in mind is the Georgia DPH Measles webpage. It has up-to-date guidance, clinical resources, and outbreak information. You want to bookmark this so you can quickly check recommendations, reporting procedures, or testing guidance whenever you need it. And finally, if you have any questions or need guidance, don't hesitate to reach out. Thank you.
Thank you so much, Vanessa. I'm going to invite both Vanessa and David to come back on camera, and let's talk about some of the questions we got in. Thank you guys so much. We have a number of questions, both that were submitted early and that have been now submitted through the Q&A. So I'm just going to kind of direct these to y'all in no particular order. But Vanessa, you talked several times about obviously AIIR, or airborne infection isolation rooms, would be the best choice we have. But for those facilities, and thinking about even doctors' offices, urgent cares, or ERs that don't have a airborne isolation room, I think you've said at least a private space. So can you talk a little bit more about, like, maybe even a hierarchy of, if you don't have AIR, what are your other options that can keep, and I really loved that you said, not just other patients, but your staff safe. We don't know what our staff are going home to, and we want to make sure that they're not going to bring something back home with them that could hurt their own family members. So yeah, help us understand isolation in ways that are manageable.
Yeah, absolutely. Thank you for that question. So of course, if we're talking about it in a hierarchy ways, negative pressure is, the gold standard. That is the best. I know that a lot of smaller clinics, some hospitals even don't have access to that. And this is where that planning slide comes in. You want to identify a room that is close to an exit where the PUI, the person, the suspect case is not having to walk through, an emergency waiting room or, high traffic areas. Um, you want to be able to have at least, at the very least, a private room with the door closed. Hopefully, you are aware of how the air exchange works. If that room also shares air with, adjacent rooms or maybe even, across the hall. But at the very least, a private room with the door that can close. And if that is what you are using, and that patient leaves, we know that measles is highly infectious. It is airborne. And after somebody leaves that space, the virus is able to linger on for 2 hours so that that room is not one that is used.
Thank you. And then just to add on that, because I know there's a question about, for instance, the use of a portable HEPA filter if I don't have an airborne isolation room. And what is your take on portable HEPA filters being added to a room that perhaps doesn't have negative pressure?
Um, I would say that that is probably a question that should be directed to individuals that work with HEPA filters. I know that the infection control guidance for healthcare facilities have some discussions about that, but really your main go-to would be your HVAC people, your facility managers, to have those discussions to decide if that would be appropriate. Again, I think that the important thing here is a private room that is not to be used and that is can quickly be accessed via a different entrance and they can exit.
Thank you. All right, David, there were several questions that came in about things like when do you decide to test for measles and how do we test for measles, and thinking about all the kids that are probably going to come into emergency departments between Thanksgiving holiday through New Year's with some sort of snotty nose, weeping eyes. How do we sort this out so we're not over testing or under testing and that we're really catching these cases?
Yeah, I mean, it's all about index of suspicion. There's going to be hundreds and hundreds and hundreds and thousands of children with viral URI symptoms coming in over the next months, just like they do every single winter. Um, Unfortunately, measles is approaching an endemic state in this country, and so we're probably going to be reevaluating how it's like how we thought about COVID in March 2020 versus COVID in even just a year later or a year and a half later. So these processes will be ongoing, but really the biggest thing is index of suspicion, which is directly related to immunization status and potential exposure, would be my view. And always erring on the side of caution, even though that will take up additional resources until you can rule out measles. Play it safe. Get directives from your local infectious disease experts and the Georgia Department of Health or whatever Department of Health, whatever state you are in, and let the experts guide you. It's always better to ask, to make that phone call and to be told, I'm not, this is of low concern, rather than the other way around, which is, ups, we had a measles case in the ED, 250 people were potentially exposed, including kids with, lymphoma. So definitely erring on the side of caution is the right thing to do.
Yeah, and I suppose that during COVID, when we had so many, we were just inundated with so many cases. I think there was a lot of like cohorting and saying, well, we could have a sick waiting room and putting these people in sort of spaces together. But this is the situation where we don't want to spread measles to kids who don't have it yet. So that becomes even more complicated, that some of the strategies we might have used before are not safe to use in something like this.
Measles is highly, highly contagious. That is why it's such a concern. It is way more contagious than COVID. It is highly contagious and spreads very quickly. and is also, if you remember some of my slides, it is virulent. And so that's why it's got that nasty combination. Um, most physicians and other providers today have not, most as in probably more than 50%, myself included, have not had to treat sick kids with measles. That's going to change, unfortunately.
Yeah, so we need providers out there of all kinds to be on the lookout. And I'm glad you mentioned people like our environmental services employees and things like that, because we want to keep them safe as well. So how you're identifying a room and marking it as please don't enter is really important, because we need to not, in many places, signs that say don't enter, we typically think we mean that except for EVS, who's going to pull out your trash, or the tech who's looking for a piece of equipment. And these are situations where we really want to make sure that that's clear about what people should do and what their behavior is around these spaces that are contaminated or potentially contaminated. I want to ask a couple questions about a little bit more leaning into the IPC stuff. And Vanessa, I'm going to press on your knowledge of this. I think this idea of 3 feet, 6 feet, what is the distance, and how big is an airspace, if you will, around a measles patient?
Yeah. So when it comes to identifying who's considered a close contact, I mentioned in one of my slides that we look at factors of, what the room that suspect patient was in. Where does that room share air handling with? So we've had a situation where we had a positive case that was sitting in the ED waiting room, for example. And of course, your immediate thought would be, everybody who was in that room. But it also led to, well, we found out that ED waiting room was also sharing air handling with the admission floors above. So we also had to pull the list for the individuals that were admitted to the floor above. And they did not have direct contact with the case per se, but because of that shared air, they were potentially exposed, and we would have to look at it on a case by case. So I know that, with COVID, we think of 6 feet or 3 feet, and that's what you consider, how long were they there? Was it an extended period of time? But with measles, again, because it's highly infectious, that doesn't necessarily apply. You don't have to
Okay,
come in direct contact.
excellent. All right. And so one more just clarifying question about that, because I know on one of your slides, you did mention the 2 hours, of course, but the 30 minutes ahead of arrival. And I just want to make sure people are understanding what they're looking for in that case.
Yeah, so that's a really good question, one that we get a lot. So why do we consider 30 minutes before and 2 hours after? So we've all been to a doctor's office or a waiting room, and we have found that 30 minutes is usually the wait time on a good day, right? Usually it's longer, but we give ourselves that 30-minute wiggle room to kind of capture anyone that might have been lingering around. And this is again because measles is highly infectious. So we want to ensure that we are not missing anyone that could potentially go out to the community and, cause a wider spread. So we always consider 30 minutes prior to that patient came in, the suspect case, and 2 hours after to give us that buffer.
Excellent. Thank you. And then I just want to touch on a couple different populations of people and thinking about vaccinations. So first of all, are there any people that need to be boosted? So that's question one. I mean, especially speaking as somebody who's not at the before 57, but pushing, knocking hard on that. So thinking about people that might need boosters, thinking about our college students, people coming back from college, are there other populations of folks that we need to be concerned about, in shared housing or things like that? And then, I think one of the other questions about, if we needed to roll out another vaccine, are we pretty well set for this vaccine? Is this something where we're going to deal with, for instance, if we do end up with bigger outbreaks, shortages and concerns about who is eligible and things like that?
Yeah, so CDC has a really good MMWR and ACIP guidelines that outline vaccination and like presumptive immunity and things of that nature when it comes to measles and MMR. But generally, I know I discussed some presumptive immunity. So generally, if you have your full series or full dose, which means the 2 doses of MMR, you are considered protected, right? Now, we have gray areas where people have had blood work done and their IgG comes back negative, even though they've had 2 doses of MMR. So ACIP guidelines, again, say that documented doses supersede any titers that were done. So we're going to go based off of that. So you hear questions now with all of the measles activity that's going on nationwide. People are calling their providers. We even get a lot of calls to public health asking, I do have 2 doses of MMR. Do I need a third dose? Do I need a booster? And the short answer is no. If you have the 2 doses of MMR, you do not need a booster. Now, there might be, again, some gray areas and other situations that, would be the recommendation would be to discuss that with your provider because we have immunocompromised individuals, we have the non-responders, the ones that have documented doses but are negative on blood work. But the short answer is if you have 2 doses, you are considered immune and you don't need a booster.
Excellent. Thank you for that. All right. So just a couple other questions, and whoever knows this, please answer. Certainly a question in the Q&A about Dr. Greenky mentioned blindness. And is blindness something that is then a permanent vision loss? Or is this something that is possible to regain once the illness has run its course?
I don't know the answer to that. My guess is it's along the lines of permanent. I don't think it's a transient
Okay.
thing, but I don't know the answer to that.
All right. Vanessa, do you have any idea? Otherwise, we'll leave that one up. We'll just do a little sleuthing.
I fortunately have not had experience with that, but I'm happy to look into it and get back to you all with some answers.
Yeah, we like to put together our Q&A stuff, so we will try to get that answer for y'all. All right, a couple of things about, for instance, other IPC, and then we're going to have to wrap it up here. Are conventional hospital grade virucidal wipes and things like that appropriate and effective in this case? And are there any other precautions that people should take? Like you mentioned airborne isolation, which is a fit tested N95 or equivalent, but should people be wearing a gown, eye protection in these cases?
Yeah, so again, measles is airborne. I think Dr. Greenky mentioned earlier, if you have a patient who is positive for measles and is, vomiting or, not able to, or urinating on themselves or had diarrhea. So of course you would apply additional precautions. My one answer would be, the respiratory protection.
Yeah, and there was a question in the chat about eye coverage. I was reviewing the CHOA guidelines just now to double check, and airborne precautions does not include eye coverage. Special respiratory pathogens does, so novel respiratory pathogens. Look, if you're going to intubate a kid with measles, I would probably wear eye coverage, if you're able to. From what I'm seeing, this would be something we could ask. I'm sure that we could get a quick answer on this, but from what I'm seeing, looking at our recommendations, it would just be straight airborne precautions for regular measles case.
Yeah, I agree.
Yeah. You don't want whatever a kid's going to cough at you when you're up close, whether that's getting the swab or, doing a nasal suction or intubation. You don't want any of that. So, we talked about the identify, isolate, inform model, and I like David, that you mentioned early, like, really identifying risk early and thinking about these things. At some point, well, yes, we want you to think about measles, but if somebody's got a fever and you don't want it, it doesn't matter what the next and is, right? So you want to protect yourself. And in these cases, we need for people to be thinking about fever and a rash, fever and runny nose, and those other questions about exposure and travel, immunization status, really so that we can implement, first and foremost, our own respiratory protection, and then move out from that to all the other people we need to protect. So, if a patient, as Vanessa said, if a patient can tolerate a mask, I think these are really, sorry, I think that was David, but if a patient can tolerate a mask, great. If they can't, okay, we're still going to have to move forward with these other pieces. So I think listen to your infection preventionists, take advantage of the resources that Vanessa has supplied in this slide deck. And I know, David, there'll be a lot of interest in your EPIC questionnaire, which is great. That's certainly something that people can try to implement on their own. We don't put N95 respirators on people who have not been fit tested, but certainly a good fitting mask is a good substitute for that. And then thinking about what your airflow looks like in your waiting areas. Even if you can't separate out people, you might be able to congregate folks and really look at the airflow patterns in those spaces to reduce the risk that's going to be inevitable for whatever respiratory pathogen they're going to have this winter. Okay, well, I want to thank you guys so much. David and Vanessa, what a pleasure, and what a great list of questions. We will try to get as many of these questions answered and write up some short answers. We're going to do a couple quick poll questions here. And then we will let folks go. All right. Next poll question, first poll question. How confident do you feel now about the best practices in measles preparedness? The Likert scale from not at all confident to completely confident. Give folks just a minute. All right. Yasmin, do we have some answers? Here we go. All right. So fairly confident. We definitely moved up significantly in that. And I'm really happy with that. I know that there's a lot to this and a lot of questions we didn't get to, but I think that overall, I hope that folks do walk away with this knowing that this is manageable, but it can feel overwhelming. There's a lot to do. There's a lot to think about. And it's an issue we think that we could make better with a lot of public health information. Yasmin, do we have one more poll question, or is that it?
Just the one.
Excellent. All right. Thank you. So thank you very much. There is a survey to complete, which will be provided in the chat. So if you can, please complete that survey. Again, my thanks to David and Vanessa. I know I'm a poor substitute for Gavin, but I'm really glad to have been here with you today and learning more about measles myself, and having these resources, I think, is a very great step forward. So really appreciate that. All right. So on your screen, you'll see the QR code, and then we have our next upcoming session in about mid-November. So we hope everybody enjoys a Thanksgiving meal before you get to find out about foodborne illnesses, which we'll be doing before the Christmas holidays. So there's a registration link there. So thank you guys so much. We really appreciate your time and attendance. And as they used to say, be safe out there. Thank you all.